where various countries have taken legislative measures, and one of them being in Japan in 2006, a law on elder abuse prevention and caregiver support. So I think with this happening, we are quite happy that Heritage Foundation, since its establishment in 94, we have promoted a lot of positive and healthy aging over it's 27 years since we established. We have done a lot of work on lifelong learning through, training programs, sensitization workshop, computer training for the senior citizens. And we have, in the last 1 year time, we have done little over 80 programs, 65, 70 programs. And one of the important programs that we have conducted is what is called Executive Development Training Program for the chief functionaries of old age homes funded by the governments, both in government of India as well as state governments, focused in Tamil Nadu and Telangana. We have also trained social workers, doctors, managers, yoga therapists in specific skills, and this is an ongoing process. We'll continue to do that. Wonderful program that we had was on the cooks program for cooks in the old age homes. The reason we have done is, when we have met all these old people in the old age homes, 95% of them have been abused and sent to old age homes. That is the reason we have taken a lot of pains to see that it happens. Before I invite Dr. Lakshmi to, was been very kind to, moderate this session, I would definitely want to we'll keep sending this message now and then in the, chat box. Please fill in the feedback form to be eligible for e-certificate at the end of 3 days. Some of you have mentioned to us in email that you forgot, you probably clicked it wrongly and things like that. Ensure that you fill it up today, and then we'll handle what to do about the rest of the past 2 days. Number two, some of you are asking for presentations, and over the presentations, please write to us what exactly you want. We'll be very happy to share with that, because these are all the presentations made by people from abroad. We would be very happy to share them with you, and including those which are from India, 3 people. And those people who would like to comment in addition to what you are given in the, in the feedback, write to us. Because if you think that we should do something different, something more, we should better our improvement, that will be very, very nice if we can get back. Now we wish to also, I'm requesting Dr. Lakshmi to close the session by 12:45, because we want to spend 15 minutes thereafter with some formalities that we think are important for us to go through. And therefore, I would request Dr. Lakshmi and the speakers to bear in mind 15 minutes to 16 minutes is a presentation, your talk, and thereafter there is a time permitting. If time permits, I'm very sure you can also have some discussions. Now, we would like to at 12:45, I would request the participants to be ready when we announce. We want to take a picture of all of you. Those of you who would like to show off your face and show off your dress up, we'll be very happy to have you taking the pictures. There will be 6 to 8 pages of screenshots we need to take. So be a little patient to ensure that your picture comes in, and be a little patient also to wait for your turn to come till we say closed off. Don't do that. Don't be impatient. We request you to be a little patient to do that. Please don't miss the opportunity of taking a picture in the midst of some of the international speakers who are coming. They would also be very happy to be part of that. And I'm requesting the feedback link to be posted only after this photograph is taken, so that there's no confusion. A lot of people keep asking, and we'll put this in chat box regularly to say that you have to wait for your turn to fill up the form. And we are very happy that you all have registered and taking part in this program, and I hope you benefit this program. Now it's my turn to introduce Dr. Lakshmi, who is, the three partners with Heritage Foundation has been, I've already mentioned. I don't want to repeat it. Dr. Lakshmi is an interesting person who has been doing a lot of work in social sciences, and particularly in social work, and focus a lot on aging. She has brought out a book, very lovely book, which I have a copy of the book. I hope I'm able to show it to you. 1 minute. Yeah. So she has brought a beautiful book on what is called active aging dynamics in the post era. So those of you who are interested in seeing, probably you can write to her and see that this book is made available to you, and she'll be very happy to connect you to where to acquire this book from. I think this is our pleasure to introduce Dr. Lakshmi. Dr. Lakshmi, kindly take over, run this program till 12:45 before we send you a warning 5 minutes before. Thank you very much, and all the very best to all the speakers and to the moderator. Thank you.
Thank you, Gangadharan sir. Hope I'm audible.
Absolutely.
Good morning. We have reached the final day of the international seminar on elder abuse awareness organized by Heritage Foundation Hyderabad in collaboration with the Center for Gerontology, Department of Social Work, Central University of Kerala, Department of Social Work, Bharathidasan University, and Madras School of Social Work. So awareness generation is one of the effective approaches in sensitizing the society regarding any issue. Decision to create awareness regarding elder abuse by organizing an international seminar is one of the effective strategies. For the past 2 days, we have got insight into various aspects of elder abuse. And today's speakers are Dr. Nugro from Universitas Trisakti, Indonesia, Dr. Shiromi Madhuvage, Ministry of Health, Sri Lanka, and Mr. James from Kenya, and Dr. Anand Ambali from Karnataka. Welcome you all to the International Seminar on Elder Abuse. Each of the speakers can speak for about 15 minutes, and questions from the participants will be taken at the end of all the 4 sessions. Hope that is okay for all the speakers. The first speaker is Dr. Nugro, and I am glad to introduce Dr. Nugro to you all. He is an East-West Center grantee in the year 1989 and Associate Professor in Public Health and Medical Nutrition and former Associate Dean of the Medical Faculty, Universitas Trisakti in Jakarta, Indonesia. He was born in Washington, D.C. in the year 1952. He holds MD from Universitas Trisakti, Jakarta in 1986. He has special training in applied nutrition, nutritional epidemiology, tropical disease control, disaster management, humanitarian assistance, and international peacekeeping and gerontology. He is also the former head of Indonesia Research on Aging Population Network, formed in 1998, a population center network established by the Ministry of Population and Family Planning, Republic of Indonesia. Presently, he is a senior advisor and a researcher at the Center for Geriatric and Nutritional Studies, Universitas Trisakti. Dr. Nugro received the Presidential Outstanding Lecture Award in the year 1997. He is the former member, vice chairperson, representing civil society in the Presidential National Commission for Older Persons of the Republic of Indonesia. He is involved in policy and programs in aging at the national and international levels. His current research and publication focuses on population aging, community-based home care, quality of life, and social quality of the aged, as well as active and healthy aging. He is actively involved in instrument development on COVID-19 mitigation LTC facilities in Indonesia in the current year. So I have made a very, very brief presentation of the biodata of Dr. Nugro. Actually, he has a lot of credentials. Once again, I welcome Dr. Nugro, and I request you to take over the session. It's over to you, Dr. Nugro.
Thank you, Dr. Lakshmi, for your kind introduction, and thanking again to Dr. Gangadharan. Time flies so quickly, 20 years that I've met this distinguished person in the field of active aging ever since the active aging concept was initiated by the United Nations as well as WHO. So if I may share my...
Yeah, that should be good. Yeah.
Yes, okay. Take my... Oh. Self-abuse. Right, yes, okay, I'm sorry. Okay. Right, let me see here. Okay, so today I will be talking about elder abuse, global perspective, and of course, using my comments in the Indonesian situation presently. I will start by talking about maybe something related to the pandemic, especially as it's related to my country. And then, of course, the global situation as I take a public health epidemiological perspective. And afterwards, I will be giving something of what is happening the last year in Indonesia. So when we talk about the pandemic, we are at present entering our third spike. Yeah? The first, this is the second year, and this is we're entering the third spike. And of course, this happened because of the Eid celebrations. And of course, there are about 3 types of variants in our country has been detected in several cities in Indonesia. Of course, people are getting a little bit, well, what do you call that? They are very restless nowadays, and to comply with the health protocol is not very conducive in terms of how they comply to these protocol. Okay, now, so actually I will show you the prevalence here and the prevalence of elderly abuse as measured by the conflict tactics scale by Palmer and co-workers. And it has a range of 0.2 to 4.9%. And of course, as we see, there are some outliers. And in this case, it was China and Nigeria. And then we have the elder abuse types, of course, that has been stated again and again for the 2 previous days about this typology. And of course, the most striking one is naturally the emotional abuse, and then followed by financial as well as physical and sexual abuse. Now, there is also a list here of risk factors, and this actually focusing more on physical disability. Before that, also there is the cognitive impairment and low income and age. The older you are, the more you are at risk, and of course the gender, mostly the majority of them being women, because of the majority of the elderly population are women. And there is also financial dependence as well as marginality in terms of race and ethnicity in a certain country. And as stated, I think at the second day, that there is also the case of ageism. And of course, in every country, it is always social culturally based. So this is also maybe what had been considered through the centuries as normal, but maybe in our modern society, it is not. So we have to comply with the law and regulation of the present day. And then here also Palmer had done some prevention strategies that could be undertaken. And of course, the most important thing is intervention on the caregiver. I think that is quite the key to handle this abuse, as well as money management for the elderly. And then hotlines, I think these are our helplines are very useful, because during my tenure in the National Commission, we had a very hectic hotline. So, and then nowadays, because we are now enacting a new law on older person welfare, which has not gone through Parliament yet, then this helpline has been coordinated by social services at present, as well as also the so-called shelter, safe houses. That is also important for providing temporary shelter for them. and also the multidisciplinary, mostly related to social affairs, health. If we have also women's rights and also enforcement, both legal as well as police enforcement. And here is a study also done by Jin, and who summarized about the abuse in different settings, and then found that globally there was nearly 17% in the community of abuse. And of course, this, as many speakers have stated before, is just the tip of the iceberg. This had been done by studying around 9 of 55 studies that covered around 140 million people. Now, in the institutions, most of the elderly abuse is done by the staff. This is nearly 65%. And the typology of abuse, as we see here, are psychological, physical, financial, neglect, and lastly, but not leastly, sexual. And this is also a study done by Deng, who studied people with dementia in the United States. And the type of abuse on people with dementia, who are elderly, of course, are psychological, around 30 to 60%. And then there's also physical abuse that is a rather wide range, 3 to nearly 25%. And it has to be noted that the underlying abuse is also there. So there is multiple forms of abuse that can be detected from each individual patient. Around 30 to 60%. And then there's also physical abuse. Of course, there was another study by Baker in 2016 on interventions of elderly abuse. And this was rather a larger study with 7 studies and nearly 2,000 elderly and 750 significant people in the US, Taiwan, and UK. However, the risk of bias was very high here, 40%. And what we found here were interventions that seem to work was mostly education. And this education naturally is directed to the perpetrator, and reducing those risk factors that had been listed before, as well as specific policies, which maybe in our case in Indonesia, will be showing you what we have been doing the last year, as well as legislation, and then how to increase the detection rates, and then of course, victim targeted programs, and of course, rehab for the perpetrator. Now, this is actually, I found from, this is actually using the data that was funded by UNFPA several years ago on elder abuse in India, where the prevalence at that time was around nearly 12%. And the main risk factor here was having disability and decreased functional ability, as well as occurring more in the urban areas. As we see, the disabilities here that are more than one disability, and in terms of gender, women are more at risk, that is more than 3 times at risk as compared to men, who are nearly 2 times at risk. Now, here is what's happening here in my country, Indonesia, during the past year. Of course, in terms of reports, violence on women, there is had been a 70% increase, while the complaints during the COVID was actually lowered, around -2%. While the trends in violence, if we do a comparison between the pre-COVID and the COVID itself, then during the pre-COVID, there was a decrease. But however, during the COVID, there had been an increase. And this is actually from the National Commission from Women, as reported by an association of Indonesian Women for Justice. This is the public legal assistance that is provided for women whenever they are in cases of mostly domestic violence. And here is the new protocol, actually, just last year in May, that was funded by UNFPA, and this was a regulation that was issued by the Ministry of Women's Protection and Child Protection. And they had divided this into like 6 subsections on protection of women's rights. This is showing you how they handle the complaints and provide assistance services, and then how to do the referral, health referrals, as well as the referrals to the safe house and shelter, as well as psychosocial services and legal consultation. Okay. Now, presently, the legislation, there is a plan being deliberated by Parliament, and this is entitled The Eradication of Sexual Violence. However, this is a little bit, is sluggish, yeah, going through Parliament. I don't know why, but it seems to be like that. And it is actually based on 2 established law. Before that, that was the Child Protection Law, as well as the Eradication of Domestic Violence in the Household Law. Okay, I think that's actually the end. By ending this, during the COVID, what we should do, besides focusing on the health protocol, is having a balanced nutrition diet and, of course, routine exercise, even though we are isolated at home. A lot of meditation and mindfulness, enough sleep, 6 hours daily, usually from 10 in the evening until 3 in the morning, and then brain exercise and social interaction with our peers, our young co-workers, as well as family. Okay, mahalo and namaste. Thank you.
Okay, thank you, Dr. Nugro. It was a very, very insightful and very crisp presentation regarding elder abuse at global perspective. Especially, you have made us to understand the risk factors for elderly at the global level, and the prevention strategies which are proposed by you are very, very excellent. Especially, you mentioned about caregiver intervention. That's what has majorly also been done by Heritage Foundation of India. So thank you very much. I think participants, is it okay for you to have the questions at the end of all the 4 sessions?
Yep, I think so. I can.
Okay.
Yeah.
Yes. Thank you very much, Dr.
Yeah.
Nugro.
All right. I'm going to stop the share.
Yeah. Good. That's fine. Thank you.
Yeah, I was looking for that button. Okay.
That's okay.
Then we can move on to the next speaker. Dr. Shiromi.
Yeah, hello.
Yeah, yes, madam. Then we can start.
Yeah.
Nice to see you. Yeah.
Thank you, you too. And shall I get the access to this?
Yeah. I need to introduce yourself. By that time, the committee will give you the access.
Okay.
So, Dr. Shiromi Madhuvage, consultant community physician, public health specialist, Ministry of Health, Sri Lanka, a senior consultant in public health board certified by the Postgraduate Institute of Medicine, University of Colombo, Sri Lanka. Extensive work she has done. She has experience in public health programs, including elderly care and disability care programs related to planning, implementation, monitoring, and evaluation nationally and internationally. She is also the council member of the National Council for Elderly, Sri Lanka, appointed by His Excellency, the President of Sri Lanka. Currently working as the consultant community physician in the field of elderly and disability care attached to the unit of youth, elderly and disability, Ministry of Health, Sri Lanka. She also has scope of public health service, extends from advocacy program, policy guidelines, and strategy development to community-based public health programs with special focus to population vulnerable groups. She has experience in holding many professional partnerships with international, other national level agencies and non-governmental organizations in relation to various public health fields, including elderly and disability care. She is also undertaking undergraduate training and postgraduate training on elderly and disability and rehabilitation, being the lecturer and an examiner in the Postgraduate Institute of Medicine and a visiting lecturer to the Allied Science Faculty of Kothalwala Defence University, Sri Lanka. She is also a researcher with skills in conducting many research and experience in supervising research projects and publications of many scientific papers, journal articles, including International Handbook of Elder Abuse and Mistreatment. Obtained competencies in providing technical expertise in conducting international and national level scientific conferences, including being the conference chair for International Conference of Gerontology and Geriatric Medicine in 2019 and 2020. She is also the council member and the founder member of the Sri Lanka Association of Geriatric Medicine, Sri Lanka, member of the Sri Lanka Medical Council, Sri Lanka, member of Sri Lanka Medical Association, and the College of Community Physicians in Sri Lanka. She's also serving as an honorary member of Council of UN International Institute on Aging, Malta. Welcome you, Dr. Shiromi, and it's over to you. Nice meeting you.
Professor Lakshmi. And thank you very much, Dr. Gangadharan and the Heritage Foundation for the kind invitation. And I would like to share some views related to Sri Lankan aspects of elder abuse as well. So my discussion based on the overview of Sri Lankan elderly population and what we have experienced during the pandemic, as well as related to elder abuse situations as well. So coming to the presentation, we have in Sri Lanka, we have got very fast, rapidly growing aging population. So currently our population is 22 million. Out of that 22 million, 12.4% of elders are there. So with that, when it comes to the sex-wise, the females are more than the males related to elderly population, which is in par with the global situation as well. And most of the elderly people are situated, or the setting of their place of residence is rural sector than the urban and the estate. So that is the in general distribution, geographical distribution and the demographic status of their thing. When it comes to the pandemic, I think this is the general COVID situation what we have experienced. So we got the first reported case done last year, March 11th. And then from that time, different durations, we got different types of waves or the episodes. So this is currently we are experiencing the third episode or the third wave of the pandemic. So when it compared to the first and the second waves, this time we have got a little bit of a severity, the more severe that the incidences and the prevalences are more compared to two early episodes. And up to 14 June, the total number of confirmed cases were more than 2 lakhs, and then the deaths were more than 2,000. So, but the thing is, of the reported cases, the biggest number we got out of all the population, the elderly are the more vulnerable group, as well as the people, those who have got infected the COVID-19 disease. And also with the travel restrictions and the lockdown measures, we have identified during these episodes, elders have got really lot of problems. So of those problems, their main concern was confined to the home. And in a way, we look at that, we always say that when we are promoting aging, active aging, or the elderly promotive activities, we always say that you have to be with your family, we are trying to looking after them within the family and all, so on, and those type of things. But when it comes to the pandemic and restrictions, these elders are not very happy to be in a long time confined to their families. They wanted to go out. They wanted to go and share their ideas, share their experience with their peers. So that is their main concern, what we have identified from them. And also with this lockdown and the travel restrictions of those during these episodes, what we had to impose, we have identified many health, social, economic challenges appeared among this elderly group. Actually, why I am referring these things have given a very close association with the elder abuse as well. So these were found actually, we have done some surveys, and especially the focus group discussions, as well as on and off very frequently. We have connected these elders through telephones, and then we interviewed them, we asked, because at the ground level, we have a very sound public health system as well as the social service system in Sri Lanka. So at ground level, we have, when it comes to health side, we have a primary healthcare workers who goes to house, like public health midwives and other public health nursing officers, medical officer of health. There's a well-established system in the community in Sri Lanka when it comes to the health side. Same like, and the social side also, we have a very sound services related to ground level. So we have elder rights promotion officers. Their main duty is to look after the well-being, social well-being of the elderly at the ground level. Apart from this elder rights promotion officers, we have a social service officers. So they also look after the social well-being of these elderly at the ground level. And always this health side ground level workers and the social side ground level workers, they are very connected. So that is the sound mechanism what we are having, or the existing system. So through that system, we always geared to get the information and provide the services even during this pandemic. So that is the situation prevailing in Sri Lanka even during this pandemic. And that's how we got the very first-hand information from these elders who are restricted or confined in the homes. And also of the health challenges, we have identified more elders are suffering from non-communicable disease. I think it's a worldwide scenario, even it applicable to Sri Lanka as well. So when they are confined to homes, they have a lot of problems how to get their medicines and how to follow up the clinic visits and all sorts of things. And also they are all physical activities, or daily physical activities were restricted. They were confined to home. Because at the ground level in Sri Lanka, we have a lot of elderly clubs and elderly committees. So what they are doing is they are just functioning like day centers. So most of the elders used to come in the morning to these committees or the elderly clubs, and they spend a day there. They do some physical activities and then social activities and recreational activities. Also at the end of the day, they go back to their own home. So that is the most of the elders have that type of daily routine. So all these things were limited. So that was a worrying factor that they had during this pandemic very much. And also with this access to healthcare, the clinic visits and how to purchase drugs and all those things were problems among them. And also there are some reported incidents of home injuries also, because usually the school children, they go to school, and then during the daytime, that was the situation on that everywhere. It's the same. But when it comes to the pandemic restrictions, everybody is living at the same home. So then everybody, their psychological stresses are more, and all categories of people. So then these type of small home injuries were reported. Actually, those home injuries were not intended ones, but sometimes due to some negligence or not thinking of much. So then elderly friendly environment was disturbed. Sometimes the small children, they put small toys or something on the floor, and then that caused some injuries for elderly. So those type of very minor things, because of some negligence, those things have happened. Those were reported to us. And the other thing was a lot of pets, some dogs or cats, because of them, these injuries have caused the factor for them. And also, and the other biggest or the most of the people have reported us that the maintaining the assistive devices, because there are a lot of disabled elderly, and they use wheelchairs and some other assistive devices. So maintenance of those things were restricted, and during this pandemic time, it was a problem for them. Actually, not to buy or those getting them, but the maintenance of those things. So those are the very much apart from the psychological issues, what they have undergone, the physical and the other health related issues we have come across. So the government of Sri Lanka, we have taken at the health ministry and the ground level provincial health services and the ground level health services, we all got together. We identified what are the existing services, what we can use during this time for these challenges. And we use those things, and that's how we maintain the good services for them. And apart from these health challenges, undergone the social challenges as well. As I mentioned earlier, then the social network was severely disturbed, so that it became a very negative factor for their psychology. And also we had two major traditional events during this time, April and May. And all these elders, they take these two traditional cultural events. Usually the practice is the elders take the leadership even within the family. So all these things they miss this time, and also the last year. So that was a very worrying factor for them. And also when they were living in the same house, sometimes the communication problems are there. Sometimes even when it comes to very simple things, sometimes watching the TV, the children wanted to see one channel, and then the elders wanted to see another channel, but they have one TV at home. So those type of very simple things has become a major issues within the family, because of everybody is having some sort of a disturbed psychological status during this pandemic. And those were related to some elder abuse, or mainly the emotional abuse side of the elderly. And also some caregiver issues. There are frail elders who needs lot of care, and bedridden elders, and also those who needed palliative care. So then the caregiver issues were there, because daily at the ground level, there are bigger portion of caregivers who visits daily, and then go back to their end of the day, they go back to their own families, just like that. So with the travel restrictions, they couldn't come to that service. So we, as the service providers, we all had to look after all these issues. And also getting down food items and day-to-day essential during this lockdown periods was another problem what they had undergone. So luckily we had the good system of social services and the social service officers along with the Grama Niladaris. They managed to fulfill that gap as well. the financial and micro income generation ways were restricted because most of our elders, they are engaging the household, being at home, they engage in income generation ways. So all these things were restricted because getting down some materials for them to make their income generation ways, and also to sell the products. So those are the issues or the challenges make them so much so worrying during this pandemic, and related to psychological, mainly the psychological worrying and the abuses of the among the elderly in the community. And also when it comes to the elder abuse in general, actually in Sri Lanka, as many of the other countries, like it's an underreporting. Still the real problem is hidden. And also the elder abuse was commonly done by their own family. All these factors, all these conclusion remarks we have received through the research. And also many contributory factors were identified, and old group, they are more vulnerable towards elder abusers than the young old group because they have a lot of disabilities, they are very dependent, they need a lot of caregiver services, and all those things have given the as a contributory factor for this. And also frail elders, elderly with disabilities, as I mentioned earlier, because of their dependency requirements. And also female have become higher victims than males. I think this is global scenario is applicable to Sri Lanka as well. And also financial constraints have become a major contributory factor for these people because when it comes to their dignity and the participation, all these things are connected to these issues. And also emotional abusing is a common type of abuse among elderly in Sri Lanka because we see some physical abusers as well as the neglect and all those other types as well. But when it comes to this pandemic situation, this emotional abusing is a very common thing what we have experienced. And also the measures are taken to identify the prevailing problems for elderly. And then we have given the psychological support because we have identified the emotional abuse as a major type. And as much as possible, we tried to fulfill the gaps between the household, the other house members, as well as the elderly. Actually, there are sometimes we have identified these issues as arise because of a very minor factor. That factor is based on lack of communication or lack of understanding, or just like that, a small remedy needs for us to intervene. So that's a very key factor as the service providers we should think of, because always when we are planning of programs, when we are thinking of policies, we are thinking of a broad picture. Sometimes we miss those type of small things. So, but the small things or the very minor or the very simple interventions can make a big difference for them. And also we used to have the regular telephone conversations between the elderly and the other service providers, as well as we got an opportunity, or we are lucky to have that our youth clubs came to help us, and these youth got the leadership to connect with the elderly people at home. So this generational gap, actually they identified what they really need, and youth identified what the elders think of them, and those type of things. So the generational things were a little bit minimized through this connection. And also the common thing the elders gave us was they felt lonely and isolated. And the crowded environment at home, they don't like it. Actually, as the service providers, we have a very key point there. So always we are promoting to look after the elderly being at home. So then it's our duty to promote the same time how we should make the home elderly friendly environment place. So that is the thing I think we have missed some certain instances. So we need to match both need and the environment together. So then we can get a good result. So there are associated factors for elder abuse during the pandemic. We have what identified. Actually, there are very small things what we can do. Communication problems are there. So the gaps in understanding the situation by elder and the family members. So we had the conversations and we contacted both family members as well as the elderly. So we got the ideas how both parties think of this. And then to cater and minimize the gap, we were able to do that through contacting both parties. So we have identified there are communication problems and there are poor coping skills. So all these things we can use for long-term strategies, how we are going to intervene for, because I know that everybody of us, we know these pandemics can come again and again, and the waves can come up again and again. So we need to have a long-term strategies to cater those things. And also gaps in knowledge on maintaining the friendly household environment. So then we have identified the home injuries and the unpleasant environment creating by the others to the home. So all these things we can correct through having a good friendly environment, creating a good friendly environment at home. And also the most of the elders as well as the other home household members and the community, they are very much unaware of the legal aspects of elder abuse. I think it has two sides of the same coin, like, so sometimes the people can think of, no, they need not to know all those things, but I think the other side, they should know all those things, because then only they are here to minimize those elder abuse things, because there the law and law enforcement should be there to make a discipline, especially for the countries like us. And also the health issues of all, the common health issues. Actually, what was happened was the dementia. There were a lot of dementia, elderly with dementia. So the family members, they don't know the certain types or the type of, not the type, I mean the description of the disease. What sort of a disease? Actually, when it comes to the dementia, the elders, they don't have the short-term memory, but they have the long-term memory. So sometimes they are not saying that what they can't remember what they have had for the breakfast, for the last meal or something like that, but they can tell us the very past stories. So then these family members, they take it as in the wrong end, thinking that this elder is cheating, like. So those type of very common health issues, I think the community should know what is happening and what sort of scenarios are there. Actually, the next is the nutritional requirement and the nutritional problems. And when it comes to the Sri Lankan traditional culture, the religion, all the whatever the ethnic groups, almost all of the people are more towards their religion. They believe it, they go to they worship it and all those things. Sometimes because of that, sometimes the preachings, they take it in a wrong interpretations. So sometimes they think elderly need to be vegetarians throughout. So those type of things, they sometimes no one is telling all those things, but by themselves they create all those things, which made them nutritional problems among them. So those are the common practices we have identified in the community. So those things have made a big issues during this pandemic when all the family members were at home together. So those type of things we need to give the proper guidance, proper awareness and advocacy for the people. What are the nutritional requirements and what sort of deficiencies that they undergo if they don't have the proper micro and macronutrition. And also, most of them are not aware of existing services. They don't know the hotlines of certain services. They don't know the ground situation, what are the free services that they can get. And those type, and they don't know the updated telephone contacts. So those type of things they don't know. Actually, they are not very much, even the family members, they don't know those type of things. So when we are planning the programs, those practical issues, I think we need to catch up and give the awareness and the advocacy. And also wider distance among generations in the same family, non-availability of innovative interventions. We always, as the service providers, what we think as traditions, even the service provision, we think of those giving lectures or discussions or giving policies, guidelines, or those type of things. But we need to talk to their heart, talk to their attitudes, talk to their values. And we need to think of innovative interventions. So as initiative, we have identified, so during the lockdown, we always contacted elderly and the youth. So we try to connect those two groups, giving, we are told elders to, okay, you all write and send us how you felt with about during this pandemic, about your youth, when you are living with young people at home. And at the same time, we gave the chance for the youth to do the same thing in a vice versa manner. So then we collected those things and we published 2 booklets and we gave the both groups to read out those things. So those type of small things we can do, but gives a bigger uh, outcome, bigger impact of our services. And also, I think way forward activities for sharing with others, I would like to think of these areas as well. So multi-stakeholder involvement, we need to improve if we are thinking of minimizing or prevention of elder abuse, especially at the ground level, because all my discussion today, the sharing experience is based on the ground level situation, because with the pandemic, we need to think of those things initially. So we need the political awareness as well, and also reporting should be promoted, and the legal aspects and through the policy guidelines, all these things should be strengthened through the multi-stakeholder involved, because health alone can't do this, social services alone can't do this. So everybody need to be, also even service providers, they should know what is elder abuse, how we are going to prevent it, what sort of existing systems we are having, and what sort of services we can have. And also the key place for prevention of elder abuse, we need to have the promotion of advocacy and awareness. And also introduce innovative interventions, strengthening of existing services, including social and economic security. And also, the last point, I would like to make a big voice on how we should promote active healthy aging in relation to prevention of elder abuse. Actually, if we are having a pre-planned or the planning of active aging in a early life, I think there are more chances to prevent or to avoid elder abuses at household level. So they are well dignified, they are well economically sound, their social economical security is well off. So then most of the risk factors or the associated factors we can minimize. And those are the key areas we have identified, and we are working for future way forward activities to minimize our elder abuse scenarios at household level or the ground or the community level. Much for giving this opportunity and listening and especially to hear Heritage Foundation for giving the opportunity. Thank you very much.
Thank you, Dr. Shiromi. It was a wonderful presentation of overview of Sri Lanka's elderly population, focusing on COVID-19. I'm very delighted to know about the effective public health services at the grassroots level, which is very, very essential. This makes us to understand the importance of micro level intervention. Though we speak about both macro and micro level intervention, maybe at this stage of COVID-19 pandemic, micro level intervention plays a very, very important role. I'm very much happy that Sri Lanka has such a strong grassroots level services for the elderly. So thank you very much. I think questions can be taken at the end of fourth session. Is that okay for you?
Yeah,
Yes.
thank you very much. Thank you.
Thank you so much. Then we'll move on to the next speaker. Mr. James.
Thank you.
James is there? Yeah. Dr. Shiromi, can you take away your presentation?
Meanwhile, let me introduce Mr. James. Welcome you, Mr. James. We are glad to have you here. Mr. James is from Kenya. James is the founder of SJ Remedial Care Homes in Kenya, the first and private care facility for the locals in Kenya, a hub in dementia care program. While celebrating its 7th anniversary, James is recognized as the Kenyan liaison of international organizations in Kenya. That is Pass It On Network, also an ambassador for Common Age in Kenya, a Commonwealth Association since 2018. Welcome, Mr. James, and it's over to you.
Thank you very much. Thank you to Heritage Foundation for organizing and the collaborators for this event, and I'm glad to be part of it. I'll go straight and share what I have for Kenya and part of East Africa. Thank you very much. Let's see the demographics of Kenya. Kenya has about 1.2 million people over 65 years of age, in a population of 38.6 million, representing 3.8% of the total population. We seem to have slightly more men than women. This chart shows the population distribution by age and sex. Current risk factors for elders. At the moment, we have caregiver depression, which is in a high prevalence, especially because of COVID, long working hours, and so forth. No recognition or incentives for professional carers by the government in Kenya. So the caregivers, the informal caregivers, are not recognized. They don't have a council like we have the Nursing Council of Kenya for qualified nurses and other cadres of medical personnel. Lack of financial support for potential caregivers. That means most potential caregivers, either it's a community-based organization, we don't generally get financial support from government or other institutions. Substance abuse by the caregiver. So you find there is also prevalence of this. People tend to indulge themselves in the abuse of substances, drugs and all. Perception by caregiver that taking care of elder is burdensome and without emotional reward. So you find most caregivers, we all know that it's a very tedious and sometimes very demanding job to do. So you find most caregivers giving up or getting burnout or left out by themselves. So they feel not rewarded. Intensity of care need. illnesses, or even dementia. So you find generally elders are at risk of being abused because of the care need or the demand of care or the intensity of care that they need at a particular time. Witchcraft and other myths and misconceptions. So you find witchcraft is really haunting the care department or the sector. And you find, despite wanting to give care, the witchcraft part of it, or the witchcraft, say, gives a setback. Maids, cultural maids, misconceptions has really made the prevalence of elder abuse a little bit high. SARS-CoV-2 pandemic measures, which have left the elders isolated. So you find they have a tendency to be abused in these situations. Corruption due to top-down approach in elder support program and implementation. So you find most of things that maybe the policies or even the incentives that needs to go to the elders, they don't get to them, leading to financial abuse and other abuses. Let's look at witchcraft allegations, which is really haunting this part of country, sub-Saharan region even. Witchcraft is a practice of what practitioner or a witch believed to have supernatural skill, abilities to perform magical rituals. Witchcraft is illegal in Kenya still, according to CAP 67. In Kenya, 120 elderly people are killed every year on suspicion of witchcraft, according to Police Statistics 2018 research study. The young Kenyans are murdering elderly relatives, especially those living with dementia, claiming they are witches, but it is because of wealth. In the wake of this, large disputes have increased, whereby elders feel the youth are using shortcuts to own and sell. This leaves the elder adult in an awkward situation, abused and even killed. Dementia stigma and lack of awareness is a major cause of abuse, especially in Western Kenya. Persons living with dementia have dementia-related behavioral changes. In a recent case, an elderly was beaten up in a mall just because she claimed she owned it. In Central Kenya, most people believe someone living with dementia is a curse or did something wrong to someone and was bewitched. SARS-CoV-2 measures. COVID-19 pandemic measures enacted by Centers for Disease Control and Social Physical Distancing left elders isolated, a well-known risk factor for elder abuse. Secondly, flop in stock market left elders vulnerable to financial abuse and scams due to financial instabilities and rush to salvage. What is the government doing about it? In the wake of COVID-19, we have seen increase in elder abuse in Kenya. The government has promoted and secured the rights of the older persons by enacting policies that provides an environment that recognizes, empowers, and facilitates their welfare. Also expediting of older persons care and protection bill 2018 in Kenya. Well, for the first time, we have had the expedition going on. Also recognition of home care program for the first time during the COVID period, pandemic, for the last 1 year. Financial support, we have older persons cash transfer, started in 2007 with every enlisted house of persons over 65 years entitled to about $20 per month with a stipend emergency support during COVID-19 pandemic. Well, the community seems to complain about the amount that the elders are getting. So I think, anyway, that's what the government is doing, and most of the elders are not happy about it. What is the community doing? Supporting care centers and volunteering, especially in the gardening. I've seen this happen even in my care facility garden. Community-based organization, NGOs, individuals, interventions. These are people who are coming up with groups, NGOs who are focusing their energies towards the elder support. Alliancing with health professionals to promote health in the elderly. We believe that if you're healthy, you are able to be less dependent. So this would reduce the chances of abuse. Church leaders, home visits with basic needs and spiritual support. Also, this works as a surveillance for the elders, reducing the chances of being abused in the community. Media awareness and participation, especially in social media. You find the youth are very robust in social media. You find teams talking about visiting a care facility, doing all sorts of things through the social media. Elders are now learning karate to protect themselves from physical abuses. It's quite interesting because the prevalence of abuse in Kenya is becoming a little bit of, you have to protect yourself even. Way forward, universal health care, which includes long-term care to promote health aging. This is one of the agendas of the government to have universal health care, which we are really urging for long-term care to be included. Elder empowerment and digital inclusion. We have seen financial abuses through the digital platform. So bringing it in, especially when we have money transfers through the mobile phones and all that in Kenya, it will reduce abuses if the elders are trained about it. Cultural means and mitigation and dementia awareness. We have robust teams. We have teams of organizations which are working so hard to create dementia awareness, training, caregivers curriculum introduction in schools, and making wills by elders. You find our elders are still struggling with the wills. They give verbal wills. So the training programs need to be set, even for caregivers in even tertiary levels. Chaplaincy, promoting welfare assessment. Promoting spiritual needs is very important. It will bring and harmonize the community. Community participation, integration, and collaboration in learning and research. Multi-sectoral collaboration, e.g. government, civil societies, private sectors in elevating the voice. What's the way forward? Promote and recognize stakeholders also. Innovators, academia, civil societies, investors, and governments. Most generally, you find these stakeholders are not generally recognized. They are left to handle things by themselves. Long-term care institutions, building centers of care is key, as it has shown. This works as centers of learning, demonstration, and research. Also enhances social, technological, innovative benefits. It's a gateway for healthy and active aging. These are witnessed because having for the last 7 years as experience with the care facility, I mean, it's amazing how these programs, even research, the universities are coming to do research about the community programs or elder programs. We are able to demonstrate in caregivers trainings how to use aids, walking aids, or other assistive devices. We are able, it is able to bring a center of running for caregivers, attachments for various students in various institutions. Also, it has an innovative benefit because it's a gateway for even reducing the abuse. Like one instance, I would say a lady got lost and was brought in the care facility. So urging for more centers to come up is key. Fast aging conclusion. Fast aging population. Sub-Saharan Africa projections indicate threefold older adults increase by 2050. Thus, fast tracking on pillars deterrent to elder abuse is key. So the prevalence is still high. We are still working on it. And I think this forum will be a boost towards eradicating this vice. Government. Action plan enacted, fine-tuned to supporting programs that help protect, identify, intervene, and punish perpetrators to enhance justice to older adults in Africa. So even globally, I would go for, because although Africa, especially Sub-Saharan Africa, we have really big issues. Thank you for listening. Thank you so much.
Yeah, thank you, Mr. James, for the excellent presentation. It was heartening to know that the elderly are the victims of witchcraft in Kenya. But also it is very happy to know that community-based organizations are playing very important role. Even other civic society organizations like NGOs are taking a lot of efforts to help the elderly in Kenya. Very, very interesting point which I noted is this elderly are learning karate. It's very nice. It becomes one of the very important parameters of development, empowerment. Self-protection is very, very essential. I think I've not noted this point in other places. This is very interesting. Very, very happy to hear that. So thank you very much, Mr. James, for the wonderful presentation. Maybe we can have the questions at the end of the post session. We'll move on to the next speaker, Dr. Anand Ambali. He's with us. Welcome, Dr. Anand Ambali. I'm glad to introduce you to this August gathering. Dr. Anand Ambali, Professor Geriatric Clinic, has been organizing awareness talks on elder abuse for medical, nursing, and pharmacy students, senior citizens, and police personnel since 2008. He has 2 research projects and 5 publications on elder abuse. He is also recipient of State Award 2016 from Government of Karnataka. I hope it is Karnataka Rajyotsava Prashasti for Best Geriatric Services. Fellow of Indian College of Physicians, Geriatric Society of India, Royal College of Physicians, Edinburgh, and Scholar of Commonwealth Commission, UK, for MSc Dementia from University of Stirling, Scotland, has 75 publications and 3 fellowships to his credit. He is on editorial board of various journals and has authored 2 books as co-editor and associate editor. Member of Vijayapura district in Karnataka, the Committee for Prevention of Elder Abuse, and he has organized various talks and awareness programs, organized several health checkup camps also as far as elderly senior citizens are concerned. Welcome, Dr. Anand Ambali. Nice to see you, and it's over to you.
A very good afternoon to you all, madam. Yeah, am I audible? Okay. Yeah. So I bring greetings to you from the. Am I audible?
Yes, you are.
Yeah. I bring greetings to you from the Geriatric Clinic. We started way back in 2007. This is service to the older people. Then we started a dementia clinic, and we have a special immunization clinic exclusively for older people at our hospital. And we have already adopted a village wherein we provide healthcare services at their doorsteps. And of course, we also provide home health services for the older people. So today, I'll be sharing some of the perspectives of the physician regarding elder abuse and what all the lessons I have learned out of them. And let me be frank with you all today that as a physician, I was not aware about what elder abuse meant. Then when I completed my course in the geriatric medicine, then I started knowing what exactly elder abuse looks like and feels like. And then I started reading. I made some friends from gerontology prospects, and then I came to know about details about elder abuse. It took me around 1.5 years to understand what elder abuse. Then I started putting it in my clinical practice, and that is what I am going to share. In next 15 minutes, I will be sharing what cases that I have come across in my clinical scenario, what our geriatric clinic is doing in creating awareness about abuse, what research we are doing and in the future plans, and what recommendations we can give to the institutes and senior citizens. So all these experiences are the first-hand experiences that I'm going to share with all of you regarding how we came across the cases and how we solved for them. We had a 78 years old man who had a known case of hypertension, and he presented to us with breathlessness. He was already on the 7 drugs when he came to us. Despite that, there was no relief, and symptoms kept worsening. That is how he came to our geriatric clinic. On examination, we found he has anemia and significant weight loss. Somehow we were not convinced, and we started digging him anything else you want to share. It took 3 to 4 visits in 3 to 4 months duration that he has to reveal what exactly happened to him. So we came to know from him that his property was sold and his children didn't pay even the penny from the money that they got, because of which he had a psychological trauma, and he has a financial being neglected, and of course he was neglected even for the food that he was supposed to be served. So our diagnosis as a clinician was he was suffering from hypertension, heart failure, anemia, and abuse. So the two important impact were there on him was anemia. That was because of the neglect, that he didn't get proper food even in his home. So I took the help of the psychiatrist in our team, and we initiated counseling on him, and it took at least 3 months for him to come out of that. And again, he came to the terms that he has to live, and he has to live independently with all the good emotions. So what we realized that after 6 months of his counseling and all, instead of 7 drugs, he came to only 4 drugs, and with that also he was living independently. So this is a case which for a clinician was challenging to identify, and unless he opened up, we could not have identified what was the cause for his symptoms not being relieved despite taking so many drugs. And anemia and weight loss was the symptoms that hinted me that this old man may be a victim of abuse. So that's how we went ahead and dig the history. This is a very interesting case. We had a patient with presenting with hypoglycemia, repeated hypoglycemia. 68 years old widow. She was living with diabetes, hypertension, and stroke. She was a regular follow-up to our geriatric clinic. She was admitted on emergency department at 1 a.m. Following hypoglycemia, for which it was treated, and she was sent back home the next day morning. After 1 month, again, she had a similar episode, again at 1 a.m. Again, she was brought an ambulance, and she was treated, and she was sent home, thinking it's a simple case of hypoglycemia. Third time, when she was admitted after 4 months of the last episode, we found that she was having bed sores. And again, the hypoglycemia occurred at the 1 a.m. And same thing, the whole children's came and all that they made it. And this time there was a delay in recovery, and we noticed that she had a bed sores. Then the next day, this time her sister came to take care of her, knowing that she is bedridden. And then she revealed why exactly this case was happening at 1 a.m. So the daughter-in-law was not providing the food regularly for this lady. And this lady used to take tablets for diabetes, and she used to wait that the daughter-in-law get the food. But those days she didn't get the food, and she went to the sleep without having food. And that is how she developed hypoglycemia at around 1 a.m. And why 1 a.m.? Because her son, who is alcohol dependent, he used to reach home at 1 a.m. And the moment he saw that in that entrance the room, that mother is screaming and shouting, and she had a virulent behavior, and he used to call an ambulance, and she used to brought to the hospital. So these are the reasons why this lady, why we suspected and diagnosed abuse in her, was because of the bed sores. Despite she was active, moving around, her ADOL was good, she developed bed sores. She was neglected, frequent episodes of hypoglycemia, because she was not provided, she was neglected food that she required, and she was neglected by her own family members. And being her son being alcohol dependent also had led to many social and financial issues in their home. So later, after a few months, she succumbed to the bed sores infection and all in the home. So that is a different story. But this is how this old lady has been a victim of abuse, and they presented to us. The third important case scenario I just want to present was, I just titled her as a mother from a millionaire family, because she came from a very rich family of a place. And she was admitted for having cough, fever, and we made a diagnosis of pulmonary tuberculosis on the day one itself, the day she was admitted. And after examination, we started her on tuberculosis treatment, and she started improving over the period of a week. And what was important to note here was, despite having symptoms for 1.5 months, she was not consulted any clinicians. So that hinted somewhere to our mind that there is something wrong with this lady. Why it took 1.5 months to get a lady in our own place to our medical college hospital, which is not very far. On the day of discharge, we went and told that, madam, you are now fine and you can go home. And she developed new symptoms. So no, I got a pain abdomen today, I don't want to go. Then again, we thought, okay, it's fine. Then after 3 days, again, we told her that we are going to discharge you, you can go home. And she said that, no, I got a headache today, I don't want to go home. So this is what again hinted to us that why this lady don't want to go home. She's avoiding to go home. That was a sign that was indicating that she's a victim of abuse. She doesn't want to go home. So what I thought was, by the time she was there with us for almost 18 to 20 days in the hospital, and I just told my intern and the nursing staff working there, who had become already close friends to her, just to try to dig out what is the issue, why she doesn't want to go home, what is the problem in her home. So what we came to know was she was not willing to go home because she was very happy here with the hospital, because she had a good friends, she has a new friends, she has a TV, and she used to get food on time. Her son used to get a food from a very beautiful hotel, very delicious food she used to get, and she can watch TV anytime, any serial, and she can take a nap. So there was no restriction at all. She was living the way she wanted to live, in one in a room with attached bathroom, hospital room, you can think of. And that is where she didn't want to go. She said, all things that I can do here, I am not able to do in my home. I am restricted doing all these things, so I don't want to go home. So the message here is, what we see as a clinician in the victims of abuse is they don't want to go home early. They want to stay in the hospital, because they again have to go back to the environment where there is an abuse. Okay, so all these three case scenarios which I have presented were challenges for us. Initially, in the first set, we could not able to make a diagnosis. Second, yes, the older person has to open up and have a confidence in us that this person may solve my issues. I am not going to their home and solve the core issue, but the ill effects of abuse on the older people, at least we can help them to overcome, and we solved. Now, with these intentions, what we thought was, we proposed from our geriatric clinic that the elder abuse should be considered as comorbid condition. Because why we proposed this? Because looking at the website of the Center of Disease Control, nowhere elder abuse is mentioned. Nowhere elder abuse is mentioned, because it is still considered as a social problem. Here at We Geriatric Clinic, we have been highlighting that it is a medico-social problem. It is not only social problem. And second, it should be considered as a comorbid condition, because it affects health too. I endorsed this way back in 2014 at an international seminar, and re-endorsed through this conference to all the August audience here. And I also already started mentioning the diagnosed comorbid condition as abuse on most of the OPD slips. So here we had an old man, 75, who was under depression because of, again, being financially abused. So the writing a diagnosis of depression and abuse, I started this concept here so that all clinicians be aware why he is under depression and what extra care should be provided to this gentleman who comes. So again, as all of us, we were discussing regarding the COVID instances. Yes, one good practice what we were having. I'll just show, because there were instances across India where their older people are admitted and left alone. They were not allowed to meet the people, and the relatives didn't know what exactly has happened with them. But in our institute, our administrators, they took the decision that all the senior citizen patients who are admitted, they should be allowed to meet their relatives, and even they can have food from their own home. So this prevented a lot of anguish among the older people, and most older people were at least happy that their children are coming and meeting him, or at least he's getting the food from his home. And second thing regarding abuse, what we have seen in our practice was, especially in the first wave, was the older people used to come to the non-COVID wards because we used to run geriatric services for the non-COVID people also. There they used to come and say, admit me in the hospital. Please admit me in the hospital. I don't want to stay in my home. So that was the fear and agitation that they had. Sir, I am living with the environment of abuse for last 24 every day, but 24/7. Earlier, my children used to go for the work and I used to feel happy. I used to do whatever I want. But now grandchildren, children, myself, everybody is staying in the home. It is creating nuisance to me. I want to stay in the hospital. Please admit in my hospital. This was how the few people came to our hospital to admit in general ward, because we provide free stay and free food for the older people. So coming back to the how we didn't wait for medical profession to know. We also brought the older people, senior citizens, that we tried to create awareness about what elder abuse means and what are the types. So what are your rights? So we started way back in 2008. The first activity which I conducted in whole of the Karnataka in 2008 was Elder Abuse Awareness Day through my institute, and continuously thereafter we are organizing Awareness Day for senior citizens, for medical students, for police personnel, for nursing college students, and we also empower them to know what are the rules and regulations, what are the laws governing them. So, and we also have a healthy discussion from the question. We take huge number of questions from the senior citizens and try to answer with the help of panelists that we have on the board. So this is what activities we are doing to empower the older people, what they should know. And the other important thing what we are doing is creating an intergenerational bonding. So for last 2 years, we are doing this program, connecting the younger generation with the older people. And you can see these are the whole list of medical college students where we taught them how to behave with the older people and bonding to be developed. And this is a place, especially in the MUT, where youngsters and older people are sitting together, and we are sharing their problems with each other, and they can take the opinion of either of them. So these programs of intergenerational bonding are to some extent helping the younger generation to know what the older people wants and what they mean to us. And at our geriatric clinic, we also have developed a tool to identify abuse. So most of the screening tools available are questionnaires that we have to ask to the older persons. This tool is one which is an observational tool. It, of course, it requires 2 to 3 clinical settings before completing the questionnaire. And here we don't ask any questions to the older people. We just observe what are the findings he is having and put the tick mark. And it also helps to know the type of abuse. And the score more than 5 of this will help to suggest a victim of abuse. So this questionnaire or tool was also published in various journals and presented at International Federation of Aging, again with the kind help of Dr. Gangadharan sir, who allowed me to this. This tool is yet to be validated, but we are using it at our clinic with the help of our interns and postgraduate students. So the one more try to know how the older people are abused and all. We did this study wherein we first taught them what is elder abuse and all, created awareness. Then we took the questionnaire. Out of 133 elderly who are educated, 13% reported elder abuse, and financial abuse was very common. And who abused them most? Again, the son. Their son abused us most. So again, we came across people attempting suicide because of the ill effects of elder abuse. So one of my study, clinical study of attempted suicide, we found that 7 older people were admitted because they are fed up being abused and they attempted suicide, attempted life. So this was a 5-year prospective study that we did and published recently. So what we have understood is we have to talk to caregivers, and we should also listen to them. What are their perspectives before labeling that he is a victim of abuse? And adjustment disorders are common, and burnout in caregivers has to be addressed by the clinicians. So what is the role of institute? Actually, it's an ideal place for victims of abuse because we have a team of geriatricians, psychiatrists, psychologists to support them. And we also provide food and the medicines to them so that they can feel it's comfortable and safe. And this becomes a respite for a caregiver. This is very important concept that we have bothered, wherein older people, caregivers, they feel that if the old man is staying in the hospital for a few days, they feel comfortable in the home for those things, and those undone things they can do, and the caregiver can relax for a few days. So what I learned to wrap up over the decade of services to the older people and identifying abuse. So elder abuse is a medical social issue. It should be considered as a comorbid condition. So it is definitely affecting the health of the older people. And older people with pension are better taken care than, he may be very rich, but that doesn't matter. What I felt in my clinical practice is if the older person is getting a pension, old lady is getting pension, she is better taken care in the home. And clinicians must be aware of the red flags. That is what we are doing as a Vice President of Geriatric Society of India. We are creating awareness about elder abuse among the clinicians. And of course, I have seen counseling and teamwork works in this situation, but it takes time. And handling victims of abuse is not so easy. It needs a lot of patience, and it requires experience. So a physician coming out will not be able to identify this, I can assure. And providing respite care for the caregiver is very, very important because they are burnout. And if they get the respite care, again, they will refresh and they may avoid abusing the older people. And it is always important to understand the views of both the victim as well as the abuser before we conclude something in that patient. So with these views, I convey my sincere thanks to Dr. K.R. Gangadharan sir, Heritage Foundation, for giving me this privileged opportunity, and Department of Social Work, Social Science, Central University of Kerala, and Madras School of Social Work. Thank you all for patience hearing.
Thank you, sir. Thank you, Dr. Ambali. It was a very active presentation because you have presented a lot of case studies. So from the case studies, it is very much evident that the problems of elderly are having multiple factors responsible for the problems of elderly. Maybe you also have mentioned about the perspective of the caregivers. Sometimes we also need to understand their perspective. They might be burnout. There are cases where even some of the elderly uses some abusive words even for the caregivers. So that perspective is also very, very important. So thank you very much. One more thing, along with the medication, you have identified the need for counseling for the elderly. So I'm very happy that because I am being a person from social work background, we feel very happy when especially the medical practitioners identify the role of a psychologist and counselors. Thank you very much. So now I was just going through all the chats, but there are no questions. Most of the participants are just like they are appreciating all the speakers. So Gangadharan sir, do we have to wait for 1 or 2 minutes, because you have already told me by 12:45?
Yeah, we can. I think we can straight away request people to come on the screen so that we can take the pictures.
Yeah, yes.
We can ask, we are just requesting. We are not going to wait. We are just going to ask people to come, and we will take the pictures quickly. I would request to technical team to take some pictures. Prabhakar to take some pictures, Jagan to take, whoever can take the pictures, please take the pictures.
Yeah.
so
before
that we have good quality picture with us.
Yes,
So
sir.
may I
Before-
request the participants to come on the picture, the technical team to switch on the video. It's nice that some of you, all of you, or most of you joined us for last. Nice to see Captain Singaraja there. And yeah, you can't talk, but just say hello. Very nice to see some of you here. So
Sir, just me.
go ahead.
Give me 1 second. Let me thank all the speakers on behalf of Heritage Foundation of India, Central University of Kerala, Bharatidasan University, and Madras School of Social Work for sparing your valuable time with us. Thank you. Thank you all.
No. We are clicking the pictures as you are all there. And I would request more people to come in. We may close it. Nice to see Dr. Joshi there. Dr. Joshi, my apologies that it did not reach you. Okay, fair enough. Thank you. Thank you. Now we can, all of you can feel comfortable, not in case you don't want to show your picture. Now, Dr. Lakshmi, finished? Your job is over?
Yes, sir. My job is over.
Okay. So now I think I wish that we are able to show some important people here. So let me see with today. Let's see. Spotlight to everybody. Dr. Lakshmi first. Okay. Now I go back. Let me see. This is Dr. Lakshmi. Now let me see Dr. Our friend James. Wow. Take some pictures here. Straight away, take some pictures. Don't miss it. Okay, I can't take the pictures. Okay. Now let's go to Dr. Shiromi.
Open.
Wow, that's interesting. Nice to see the pictures of all of you today. Then we'll go to Dr.
Ambali.
Dr. Ambali. Yes, he is there. Now, two of you have come. Now, let me also say, take one of our good friends who has been with us all the time with me, and Jagan, who has been part of our Heritage Foundation in the long time to come. And then I need to go to, let me see whether
Dr. Nugro is there.
Yeah, I'm trying to see. Yeah, I'm trying to see Dr. Nugro. Yeah, let me first release the video order. Nugro. I'm trying to see. Now Dr. Nugro is coming here. Spotlight. Yes. Yes.
God.
Wonderful. Nice to see. Absolutely lovely to see you people. Now let me see whether I can go to Dr. Mangaleshwaran. Dr. Mangaleshwaran. Yes. Now let's see. That's fine. I think these are all the small gratitude that we want to express to all of you. I think this is the only way that we could do is to, we are not able to give you any bouquets. We are not able to share with you any gifts. We are not able to share with you anything. We at least thought we'll do that. Now, who else is there? Now, is there any speaker that I left here in this group? Okay. Now, can I have Prabhakar coming on? The Prabhakar from our... I want the technical team now. Now, technical team consisting of, what is that person? Dr. Selvamani.
Selvamani, yeah.
Dr. Selvamani is here?
School of Social Work. Madras School of Social Work.
No,
sir?
Selvamani is from Selvamani. I think Dr. Raja Samuel is not here.
Yes. Yeah, okay.
Now, Dr. Selvamani is here?
Yes, sir.
Where are you? I'm trying to see. Where are you?
Yes,
I'm
yes,
trying
sir.
to see in my picture. 1 minute. Unless I see you, I cannot do that. 1 minute. So if you can spotlight yourself, it will be wonderful. I'm not able to see you in my film, right? Where are you, Dr. Selvamani?
Yes, here.
Okay, Selvamani is your organizing committee? 1 minute. Spotlight. Now show me your picture. That's fine.
I made it, sir. Yeah, I made it. Yeah.
Wonderful. So now you can show more people if you are having somebody. Now Tamil, I think Pugal is there.
Pugal. Where is Pugal?
Yeah.
Pugal is there?
Pugal,
Pugal, sir, technical team.
Because let me tell you, they all did a lot of work behind us, behind the scene.
Pugal,
Okay. Then Hari.
Hari. Hari not able.
Okay, we will not wait. Now Prabhakar from Heritage Foundation, Hyderabad. They're all from all the names I gave were all from Trichy, Madhu Bharatidasan University. Prabhakar has come. Now Prabhakar is here. Prabhakar is Man Friday here. Okay, thank you, Prabhakar. Now what about Sweta? Sweta and Vijay Lakshmi are there from Hyderabad. Now I'm happy to see so many. I'm happy to see so many pictures now. I think so many people are appearing on the pictures. A lovely thing to see. Now let me quickly take those pictures of lovely people in the screen now. Wonderful. Sweta has come. No. What about Vijay Lakshmi?
Shall I ask some of the participants, sir? Shall I call out?
Please call whoever you want to call. I
Yes,
love
yes.
to have.
Dr. Mishra, Amit Mishra.
You need to spot them on.
Yes.
And in the meanwhile, I'm also showing on Spotlight Dr. Vyasamurthy. Nice to see the three people, Vijay Lakshmi, Sweta, and Prabhakar together. Nice to see Mr. Vyasamurthy, who's been very active with senior citizen, who does a lot of work communicating with a lot of people on his Yago groups. Now, nice to see Dr. Narendra Kumar from Delhi. Okay, that's fine. And let's see, Dr. Hanumant, Dr. Joshi is there from Mysore. Dr. Lakshmi, your friend from Mysore is here. Dr. Lakshmi, Dr. Joshi.
Oh, okay.
He is the principal of Sharada College. Yes, let me see him now. He joined very late. And I apologize to him for missing out on inviting him. I missed sending the link. Now, Dr. Lakshmi, it's your turn to call. Dr. Mangaleshwaran, you want to spot anybody? Please do that very happily. We'll be very happy to do that.
Yeah, some of my scholars and students are also there. I don't know.
Please do that. Please do that. The best way to spot land. Mr. Singaraja has come. He's having his lunch. Yeah, he's munching his lunch. Yeah. Don't worry, Mr. Jaja. Don't worry. It's a time for you to have lunch. It's 1 o'clock. Yeah. And he's another very active person for a very long time in the field.
Sir, Gangadhara Garu, I am Dr. Nageshwar Rao, Vice President.
Nageshwar Rao, where are you, sir? Let me see where you are. 1 minute.
Yes.
He is another very senior person who is involved in. I'm trying to look at you, sir. 1 minute.
Green sheet test.
Don't worry. We'll just check. 1 minute. Where are you? Now you are here. This is another important person who does a lot of work. 1 minute. Now I have to show him on the ad spotlight. Okay, now Mr. Nageshwar Rao. So he is another gentleman who was very active in the field of aging and senior citizens associations in Hyderabad. So nice to have all of them with us.
Thank you,
Dr. Lakshmi, move on.
Yes. One of my scholars will be coming. He's doing research in the field of aging.
Yeah.
Almost about to complete and publish several articles.
Please, 1 minute. Let me remove more people here so that we can have more people coming in. Yeah. Are you showing somebody? Scholar? Yeah.
Anup, are you there?
Yes, ma'am. I'm talking now.
Where are you? I'm trying to see where are you.
My name is Anuj, sir.
Anuj.
Anup.
1 minute. I'm trying to see where. Anu. Any of you see, please let me know, Dr. Mangaleshwar and Prabhakar, any of you. ANU.
ANOOP.
ANOOP.
Yes.
Anup Chula.
Yes.
I'm trying to see where is he now. Okay, now I'm seeing him. Now 1 minute.
Sir, Gangadharan sir, this is Rajashekharan.
Okay, 1 minute, sir. Rajashekharan, nice to have you with us.
Yes.
1 minute, sir. Now I'm trying to see how can I spot now. Spotlight to everyone. Okay. Now this is Mr. Rajashekharan has come.
Yes, sir.
But your picture is not here. Very nice to have you with us. Okay. Now, Ma, your student has not come yet. 1 minute.
Rajashekharan, sir.
Yes, sir.
Yeah.
How are you?
Rajshekharan is
Fine, ma'am.
Rajshekharan is active man in yes, nice to see him from Trichy, right? Yeah.
Yes, sir. Yes, sir. Yes, sir.
Now you are sent one more person, Anup.
Yeah.
I'm trying to see why asked to start. Anup is not in the video. He's
He opened his camera, now he's there.
now 1 minute. Hold on. We all want to see spotlight everyone. See, when Dr. Lakshmi says you are an important person, how can we miss you? I think this is what we wanted to see today. Thanks a lot. I think this is an important thing. Now, I don't think I want to formally thank any of you for anything, except to say, let me also say Dr. Vatani on behalf of the Madras School of Social Work. Yes. Since Dr. Raja Samuel is not there, she's another important person in our Heritage Foundation's lot of work that we do. And she's our one of the important key resource persons. Nice to have you, ma'am. Nice
Thank
to
you,
have
sir.
I
Thank you very much.
Thank you. Please
Thank
convey
you.
this to Dr. Raja Samuel that we missed him today here.
Yes, sir. Yes, sir.
Okay.
नहीं बालाजी का नहीं है, एक माता जी का है।
Okay, so can we say big thanks to all of
समाधि
you,
ले रहा है,
all the
समाधि
speakers,
की
all the
जगह
organizers, and
समाधि
the
ले
team
हाँ।
that we were together this morning. And nice to have Mr. Raina from
अभी पता लगा लेगी मौसम
Mr. Raina also here. Nice to see you there. Oh, okay, fair enough.
गुफा से चले जाओ हार्ड
You are muted.
Mangaleshwaran, sir.
Hello, madam. Nice.
How are you, sir? Nice to
Yeah,
see
fine,
you.
madam. Fine, madam. Yeah, good to see. I think you were busy
Okay.
with moderating. Okay. How is Mohan?
Fine, sir.
Convey my regards to you.
Yes.
Okay, so Mr. Anbaragan is another important person who does a lot of work on aging. He runs one of the best old age homes in Ooty, Nilgiris. And yeah, I think I'm going to show a lot of people. If I keep showing, there is no end to what I'm going to do. So with this, I'd like to actually say big thanks to all of you, particularly the team behind me and those Dr. Lakshmi, Dr. Mangaleshwaran, Dr. Raja Samuel, these three who joined us to conduct these programs, and practically 15 speakers who kept us spellbound, absolutely spellbound. And I don't think there was any speaker. Let me tell you, it's time for me to tell you the rating of this program, usefulness, according to 2 days, 15th and 16th given by the technical team is 95%. I think the relevance of the program, quality of delivery, usefulness, I don't think we can get anything better than this rating. And we are looking forward to more such international speakers coming in the next few programs. Stay tuned for us. When we send the program, and please remember only one thing. This time, some people said they did not get the link. In case future you register and you don't get the link, please send us an email a day before, so that we'll ensure that you get the ranking. Because we are very keen reaching out to people. We want people learning, and we want to sensitize people. I think this particular program on elder abuse is so useful for sensitizing so many of you intern families. So let me not keep talking. Now I request the technical team to put on chat the feedback form. Now, Dr. Mangaleshwaran, Dr. Lakshmi, Dr. Ambali, any of you want to say anything? Most welcome to tell, but request for muting before you did it.
Nothing, sir. Thank you very much for this opportunity for collaborating with us, especially the Department of Social Works, including Bharatidas and Madras School of Social Work and our university and all. So it was a wonderful 3 days program. Very happy for that. Thank you very much.
Wonderful. And please understand, Dr. Lakshmi, you asked for a lot of trouble.
What?
You asked for a lot of trouble because we'll keep asking you to join us more often.
Yes.
Yeah.
It's not an issue. It is a privilege.
Yeah, we'll do a big program in the month of July. I think we'll discuss it with you very soon, what exactly we propose to do. I think Dr. Mangaleshwaran will take a lot of initiative in the next program. that we are talking about. Let me tell you what we plan to do, Dr. Lakshmi and the team. We are going to do an exclusive program on social work and geriatric social work, particularly geriatric social work. We are going to bring eminent people from across the world and also India. I don't think India is lacking any talents. So we are going to bring people. It's going to be a conference. Perhaps we might want to get 1,000 people to participate in this conference. We plan to have parallel groups going on as we conduct these programs, and get ready for joining us in the month of July. We will tell you the dates. Look for it. Now that you are in touch with us, don't hesitate writing to us. Anyone will be very happy to write to us. And lot of you have made a lot of comments in the chat box. Please give us some time. We will get back to every one of you. Will respond. It takes time for us to consolidate and takes time for us to go through. Please give us a time. Be rest assured. Anyone who has made any comment in the chat box, one of the team members, either Dr. Lakshmi or Dr. Mangaleshwaran or Madras Social Work, Dr. Raja Samuel or his team or Heritage Foundation or all of us will reply to you in every question. Number one. Two, all the PowerPoint presentation, all of you have asked for it. Please write to us once again. Chat box is not going to be helpful. Please write to us so that we are in a position to send you. Also remember, we cannot share everything with you in a big bulk form. It's not going to be possible. So we will ensure that this is made available to begin with in Heritage Foundation website. That we'll try to do it in the next few days' time. Now, in consultation with the rest of the partners, namely the Central University of Kerala, Bharathidasan University, Madras School of Social Work, if they wish to put this in their website, we'll also send them. But it will be definitely available in Heritage Foundation website. I must also particularly thank Mr. Subramaniam, Secretary Government of India, who came there. Despite all his efforts, time, whatever comments we have our own reservations, how much government does of what they're talking. But let us understand one thing, the government is also doing whatever they can do within their limitations. I don't want to say I'm pro-government or anti-government, but they're doing a good job on whatever they are doing. And we would like to definitely get them involved in our programs as an invitee to these programs. But we will do the program ourselves as a group with a consortium of universities and schools of social work. And we are also going to get in this programs colleges and schools of nursing, so that they are an important facet of geriatric care. So we are going to have a bigger program. Look forward to that. Our target next program, July, August, will be 1,000 participants in parallel group. I think Dr. Lakshmi, Dr. Mangaleshwaran get set for it.
Yes, sir. Certainly.
Thank you very much once again. Kindly fill in your forms. I think the Zoom link will be open till 1:30, which is 30 minutes from now. And even if you're not able to fill up these forms, don't hesitate writing to us anytime. You will all be very happy. Okay, since till such time you write your, feedback, I'm going to show some important people here who are contributing something. This is Mr. Raina. Mr. Raina is disappearing from somewhere. Okay, thank you. Now, Dr. Lakshmi, if you want to show anybody, please go ahead, do it.
No, sir. I don't know.
Okay. I'm going to show whoever is coming in there. Now, yes, Mr. KK Singh from, let me see whether I can say Mr. KK Singh from Manipur. Oh, Manipur is another important program. That's wonderful to see you like that. Mr. Singh, nice to have you with us.
Thank you, sir. Thank you.
Pleasure. It's our pleasure. Now, Mr. Chidambara Rao is there. Mr. Chidambara Rao is there. Mr. Chidambara Rao is there. Meghna is here. Meghna from here. No, Meghna from Pune is not here. Okay. Matani David. I'm trying to see whoever I can.
Yes, sir, I'm there.
Okay, I'm trying to see where are you now. And I hope I'm able to locate you. 1 minute. Now, let me also get Dr. Popley on this.
Oh,
very nice to see you here. Nice to have you with us. Thank you so much for being with us. And yes, we are going to drag you. We are going to drag you soon.
It will be my pleasure.
Please, you should join. You should join. Now, let me see, Doctor. I was looking for somebody whom I lost. No, Dr. Meghna. Mrs. Meghna. I'm trying to see where she is. I'm not able to see her.
I'm there, sir.
No, you are there, but I must locate you on my computer.